So for patients that have metastases to the liver and you're thinking about treating metastases in the liver, it would be great to go through how you determine the best way to go at those metastases, whether it's surgery or it's radiofrequency ablation or chemo or radioembolization, and then also in particular, does the number and size of those tumors impact those decisions?
I'll just start to introduce, of course, George and Dan, the fact that that's why it's nice to do it in a setting where multidisciplinary tumor board, so all the people can be at one table looking at the same scan at the same time and can discuss what each can bring to that particular person and debate whether one might be superior to another, tailored to exactly where that disease is or what the complications might be for that particular patient. And so the rest of it is up to Dan and George. So why don't you guys take it?
Obviously, for metastasis to the liver from neuroendocrine tumors, surgery is the gold standard. However, surgery is not feasible in the majority of patients, as you probably already know and already heard this morning. So only about a quarter of patients are really eligible for complete resection of their metastatic disease. The second problem with surgery is that surgery does not come without a price. So surgery can, obviously, in removing the majority of your liver, can come with morbidity and even mortality. So, and this is what we call, we examine the patient's candidacy in terms of other medical problems, the condition of their liver, and also the extent of the disease in the liver. So this is certainly a multidisciplinary discussion that we have at our tumor board every week for several patients with this disease. And sometimes we will work together to make a patient a candidate for an operation. So sometimes I will ask Dan to embolize a patient's liver before I go in and resect to shrink the tumor so I can make their tumor smaller, so I have to resect a less amount of the liver. Or I can ask George and Pam to give a systemic therapy to stabilize the disease, control the symptoms, or even shrink the disease so we can go ahead with the resection. There are several tricks we have to extend the criteria for resectability. We don't have a defined number of lesions. These tricks sort of come of management of patients with colorectal cancer that are probably more common, but we share a lot of the principles we have for metastatic colorectal cancer of the liver and apply them to patients with neuroendocrine tumors. Sometimes we do so number of lesions does not matter. What we need is about 2 of the 8 segments of the liver to remain, but we need these 2 segments to have adequate inflow, adequate outflow, adequate biliary drainage, and also we want them to be in good condition so that the liver can regrow and regenerate after our resection. Sometimes we do preoperative embolization of the hepatic artery. As I mentioned, sometimes we do a preoperative portal vein embolization to the liver that we need to resect so that we shrink this part of the tumor that we will resect so the other part of the tumor will already have grown by the time we go in to resect this half of the liver. And again, this is another example of how we work together in managing this patients.
So Dan, tell us what patients you'd like to steal from George for your treatment.
Hopefully none.
We only share, we don't steal. I think, as I had mentioned during the presentation, the things that I can offer, we never sell them as curative. And so if there's any chance that George can cut out everything and cure the patient, of course we will try to collaborate to get that patient to surgical candidacy or transplant candidacy. But there are a number of things to consider. Even if there's only one spot visible in the liver, if you took out that whole liver and looked at it under a microscope, there might be other spots. And a lot of the treatments, the more aggressive they are, like surgery, the more that they can actually stimulate the growth of what's left behind. Because the healing process also releases a lot of growth factors and that sort of thing. And so even though surgery is really the only chance for cure, there's some higher stakes involved as well. If a patient, though, is not considered a surgical candidate, then that patient ends up basically the patient of Dr. Kuntz and Dr. Fisher and mine. And the times that we would consider liver-directed therapy is when the overwhelming involvement of the whole body is centered in the liver. So if someone has a tiny little liver spot, but 50 spots in the lungs, then it does not make sense to attack the liver. So it's only when it's liver dominant or liver exclusive involvement. And even then, as we saw, there are several options. So if there's only 1 or 2 lesions, we'll use our microwave oven on a stick and basically cook those 2 little spots. But that's a very unusual circumstance. Usually by the time that we find liver metastases, there are at least dozens, if not hundreds, that are visible. And in that case, we sort of have to carpet bomb the entire liver. And the choice between chemo and radio, again, I cannot honestly tell you which one is better. But if you try one and you don't like it, or your tumors don't like it, then we'll switch to the other.
So to be honest, sometimes there is no one, and even with a tumor board, we may say, well, actually, these are the 3 options that you might think about, and these are the side effects. These are the hope for benefits, and what would be the best sequence of trying them, and then let you decide.
Are there any of these treatments that if a patient has it, it will prevent them from being able to do something else down the road?
So I'll just answer that quickly. Yes, and it depends on how many side effects a particular treatment is. So you wouldn't want to get a big blast of radiation and then think that, well, maybe I can do a big liver surgery. If you're dealing with an irradiated liver, you worry, well, will that liver, go ahead and grow like it normally would? So there may be some limitations as to how we might sequence our tools. Just in terms of eligibility for clinical trials, which is near and dear to Pam's and mine heart, is that certain treatments would make you ineligible for certain clinical trials. So in sort of a strategy of keeping options open, we might go with another treatment that seems equally reasonable so that you're still eligible for a clinical trial that might be coming downstream. Just trying to keep options open.